All right, I think we are live. I believe we did it. Okay, welcome everyone to our final NATM talk for this month. We are going to be discussing the physician practice setting today. We have two amazing women in athletic training with us today, Tara and Sarah, the rhyming here. If you would, Sarah, can you just tell us a little bit about yourself, what setting you're in right now, all that fun stuff?
Sure. I'm currently in San Diego, California, and working with a private orthopedic surgeon. So it's literally just him, RPA, myself, and then I have a couple interns that help out with kind of reaming patients and scribing notes. And then I have one front office person that does everything from phones to scheduling to insurance authorizations, you name it. So,
Awesome.
so yeah, it's definitely a small clinic. We see, I don't know, anywhere from 20, 25 patients in a half day. And then like today he's in surgery all day. So it's an admin day for me, but otherwise we're seeing patients daily and then doing admin stuff the rest of the day when he's done seeing patients.
Awesome. Awesome. And what about you, Tara?
Yeah, so I work with a orthopedic surgeon as well. I work in private practice. It's a pretty large private practice here. So in our building, we have anywhere between like 5 and 10 orthopedic surgeons here at a time. So their staffs vary. I've been at this practice a little over 4 years now in the Chicago suburbs.
Got it. And you guys are both practicing, quote unquote, as ATCs still.
Yes.
Okay. Because I think that there's a little bit, people wonder if you have to get extra certifications to be in this setting. Have either of you had to do that?
I haven't had to do anything. My question is now they just came out with the orthopedic specialty certification, and there's really no not no guidance, but do you have to do it?
Yeah.
I don't think there's, I don't think it's something that my doc would make me do. It's not going to change what I do any. And he's fully on board. I mean, he started out in the sports medicine program at Pepperdine. So that's why he's very appreciative of the athletic training background. So it's not like I ever really have to fight for my scope of practice.
That's good. And no certifications, extra certifications that you needed to get, Tara?
So I have my OTC
Okay.
because I do scrub into our surgery center. And for me, the OTC was just a checkbox. This was what the facility required.
Got it.
So that's what I have, but only because of the center needing that. No other reason.
And I could, he gave me that option, and I would have had to do the same thing. I just honestly don't have time to be in surgery because then I wouldn't get all my other stuff done.
Yeah.
So I opted not to do that.
Yeah, I'm in the secondary school setting now, but back in my first job, I was split physician practice and high school, and I was in surgery as well. And they did not require us to get our OTC cert. They kind of just trained us on the job. And I think that might vary state to state too, I guess, depending on practice acts. But I think as long as physicians are informed about our scope and our education, I don't think a lot of them, as of now, are, it's a hard, you have to get it, otherwise you can't do this. But I definitely think a lot of people are interested in going that route and getting that certification. How did you do the, because I believe there's two routes, right, Tara? Like you can either do the exam and sit for it, or you can just get the experience and kind of like the 2 years and sign off on it.
So you actually need the 2 years of experience to take the exam. So you do need to take the exam. Yeah. Yeah. So I believe there's like a formal training program for people that are not in a healthcare profession. But for athletic trainers, you would have to complete the number of hours of observation, and then you would be eligible to sit for the exam. You still have to take it.
Got it. Yeah, we get quite a few questions about that, so that's good to know. Now, how did each of you get into physician practice? Did you start out there? Did you make the transition at some point?
Go ahead, Sarah, you can go first.
So I was in a Division I, working women's basketball and a couple other sports. And, then came the time to start a family, and had spoke with my boss about maybe changing sporting assignments. And he was very willing to work with me to make it work because he had a young family as well. And then he left and nobody else was on board with making that transition work. And then I actually ended up getting pregnant with the second one like 9 months later. So I ended up being home for 7, 8 years. And then when I was looking to come back, I knew that environment was not going to work. My husband is a teacher and a coach. And so, he's gone till 10, 12 at night sometimes with his sporting assignments. So this honestly, like my whole career fell in my lap, and it works perfectly and I love it. And I've been here 7.5 years.
That's great. What about you, Tara?
So my transition happened probably 4, 5, 6, 7, almost 7 years ago. So I was working at a high school, and I was there for about 3 years, and really just had an interest in working one-on-one with a physician, and just being able to learn more, being able to have access to things like X-ray and MRI, and really just to learn new skills. So I came across a sports medicine physician who was looking to hire an athletic trainer. We met and really had, a great relationship, and I worked with him for about 3 years. And then I ended up moving, which is why I transitioned jobs.
Got it. And what have either of you found, obviously it's a completely different day to day, what is it that you maybe like more in your physician practice setting than, the typical high school or collegiate setting? And what do you maybe miss from those settings?
Yeah, I think one of the things I like about working in physician practice is the access to work with a physician one-on-one. So you get to work on your skills, see, have like a really intelligent discussion while the patient is in the office. I think it really helps like hone in on your physical skills, your, history taking ability. We get the initial intake and then all the way, sometimes even like intraoperatively. So to like see the patient progress is really interesting. I would also say what I miss. I think, being outside on a nice day still kind of sounds nice. I thought working at a high school, you really got to impact kids at a really impressionable age, which is, I think, something I miss. And I mean, I got into athletic training because I love sports and I love, being active. And that's not necessarily something that goes hand in hand with physician practice. I would say 99% of my patients are not athletes.
Right.
And I do, the doc that I work with he works with US Soccer, and he's very athletic and health conscious himself. And so he does have a following of patients for that reason. And so we get the NFL guys, we get the MLB guys, we do have a fair amount of an athletic population, and we have a lot of Medicare patients with, osteoarthritis. But I enjoy the patient interaction. I mean, 95% of our patients are awesome. I love working with them. Of course, you're going to have crazy wherever you go. But for the most part, we really have great patients. And I enjoy my staff. I mean, I really actually like coming to work every day. But then I did as well when I was at the collegiate level. I do enjoy the more quote unquote normal work hours. I'm pretty much Monday to Friday, 8 to 5:30, no travel. So that was, huge with having a family. I honestly don't, I did really enjoy the athletic part of it. Again, I think that's why the majority of us get into it, but I don't miss sitting at practice for 3 hours a day, every day. I don't.
Yeah.
Definitely. I know. I think for me, one thing I really enjoyed, especially being in surgery, because I'm an anatomy nerd, hence behind me, is seeing the anatomy open in front of you, like seeing a knee replacement done and seeing what you have learned all this time in books, and you see it in front of you, and it really helps you understand. And I felt that it helped me understand my evals better. You know, I understood the anatomy, and then when I was obviously going in rooms with physicians and seeing how they you know, did their flow of eval, I definitely adjusted mine to be more streamlined, and maybe a few tips and tricks that, you know, they've been doing this for 30 plus years. You know, I was a new grad, and so it really, I felt like, helped solidify my eval skills and my understanding of injuries and how they present, and all that fun stuff. So I enjoyed that part of it too. But I definitely think the typical 9 to 5 is what really intrigues a lot of ATs, especially women ATs, you know, that do want to have families. You know, it's different, I feel like, for women in this profession. They feel like they are being pulled multiple directions, either be at work for 12 hours a day at your high school or college, or be a mom. And I think it's important that we do have these options available to us where we can have that balance. We can have that work life, and we can have the paid time off that a lot of positions at these settings still don't have. So I think
that's where, as a profession, we need to do better.
Definitely.
Because I wholeheartedly disagree with the more normal hours.
Yeah.
When someone comes in for an interview, and if they say that, I immediately do not hire that person.
Yeah.
That is the wrong person for this job. I think that if you want to work in physician practice and you say that you want normal hours, then go work at Target. Because I mean, to be honest, that is the furthest thing that will automatically not get you a call back from me. So I think as a profession, I think, now, do I have to be here on Saturday morning? No, I don't. But at the same time, you should be changing into a setting you want, because you want to work with a different patient population. You should have a reason other than I like the hours, because that's wrong.
Completely agree. I completely agree with that. And that's good, because, you know, a lot of people have questions. How do I get into this setting? How do I get my foot in the door? So that's really helpful for people to know. You know, don't just do it for
it's the wrong reason.
Yeah.
And I think the positions, you know, at high schools and in collegiate setting that don't allow people to have a real life, like, that's where the profession needs to do better.
Totally agree. The ongoing battle, isn't it? I think that's great advice, because, you know, again, we do get so many questions about how to make the switch, but it's like, why are you making the switch? You know, I feel like we as a profession pride ourselves so much on, you know, almost caring too much. You know, we die for this job. We put our mental health and our personal time on the line to be there for our athletes and our patients. So like you said, you should just be wanting to work with a different population and a different timeline of their recovery or their treatment. Shouldn't be necessarily for the perks. Yes, there are perks.
Definitely.
But that shouldn't be the underlying.
Right. I think that eventually you'll be disappointed.
Yeah, I mean, definitely. And I can speak from personal experience. You know, like I said, I started out kind of split physician practice in secondary school. When COVID hit, you know, I wasn't at my secondary school, and I joined a new company who had us working in clinic, but it was different than my other experience in Ohio. So even within the same kind of setting, different offices have different roles for their athletic trainers. So in this one specifically, I was more of just an MA role, you know, a lot of the admin duties, a lot of just the rooming patients. And I didn't feel like I was getting that itch scratched, so to speak, of getting my hands dirty. You know, what do you guys feel like? Like, do you guys feel fulfilled in settings, and like, what can you do, and where is the line drawn of, you know, you're not able to do something necessarily?
I'm totally fulfilled. I feel like I do everything that I'm capable of doing. I mean, like I said, it's just me and a couple interns. So I'm
Right.
running that clinic. Where I'm rooming the patients, I'm drawing up the injections. He basically wants me and the interns to figure out, what is wrong with the patient and what are the steps needed to make this visit as efficient as possible. So I'm, finding out where to send them to PT. I'm doing the referrals for whatever, PT, other physicians if need be. When we're sending them to X-ray, we're ordering the MRI, the CT scan, we're doing signing them up for surgery and all that entails. So honestly, there's really nothing that I'm like, oh, wow, I really wish I could do that, that I'm not doing. I feel like I'm basically doing the same thing that I was doing, but it's in a physician office. So I feel totally fulfilled. And again, like I said, my doc has a sports medicine background. So, and I don't know if this is good or bad, it's bad, but we, as everyone knows in the state of California, still don't have licensure. So yes, I'm practicing within my scope. There really is no role delineation there, but definitely, staying within the scope of practice. So I enjoy it.
Yeah, I would agree with Sarah. I think it sounds like Sarah also works with a physician who is very supportive. And I think that's really the key in what you can do. So yeah, I couldn't imagine something else that I could do that I'm not doing. It wouldn't be within my scope. So yeah, I feel really good. I don't think there's anything else that I could do physically, mentally, or emotionally.
Yeah. I mean, and I'm doing all the, the DME, the bracing, the fitting,
Casting,
the ordering,
the
ordering of the supplies, everything. So, like Tara just said, I mean, there's not another minute in the day for me to honestly do anything else.
Yeah. Well, that sounds great. It sounds like you guys both have really good physicians kind of heading and being there to, advocate for you and let you do what you know how to do. You got this. You have your knowledge and sounds like they hand it over to you to take the reins, and that's awesome. I love to hear that. Because
I will say, sorry to interject, I
No,
just
you're
thought
good.
of this. One thing that I have totally had to learn on the job is the coding and the claims and the billing. When we switched to a new EMR 4 years ago now, and we became the billers.
Yes.
No idea what I was doing. It was a lot of trial and error, which is really makes me nervous because that's the money,
Yeah.
So that I think people need to know if this is something they really want to get into. And from my understanding, they're now incorporating some of that into the academic programs.
Yeah.
But that's all been learning on the job and trial by fire.
Yeah, definitely. I know that was the one thing that I was the most uncomfortable with, because like you said, that's where the money is. If you bill something incorrectly, or if you don't bill something that you're supposed to bill for, then that's not good. That's a whole other side of the coin that we don't really get to see, because we can't technically bill for our services, but we can bill for the services that our physicians are doing when we're in their practice. So yeah, I think that's something, we get a lot of questions again about this. Something that a lot of ATs might not consider is that you'll be in charge of a lot of this insurance stuff for these patients, and it's helpful for you to be knowledgeable about it, because when patients have questions, I can't tell you how many questions, or I've asked patients, what's your insurance, and they don't even know.
I have no idea.
And so I have to figure out where they can go, what they can do, who they can see. So I think that's definitely a side of physician practice that people might not think about when getting into this, for sure. Now let's talk, day to day, like you guys kind of already a little bit touched on it, but I think that people, ATs who are really interested in maybe making the switch, would love to know, what is a typical day like when your physician is in office and you're there helping them?
Sarah, you want to go first? Go ahead.
Sure. So basically we bring the patient, myself and my interns, we bring the patients back. We do the history, try to figure out, just like you would with an eval, what is wrong with the patient, so you know where to go from there. Send them to x-ray. Do I order an MRI? Do I get a PT referral going? Do I think they need an injection that I should maybe draw up? So I have everything ready to go so that when he walks in, it's a much quicker and more efficient process. And then we will present the patient to him, and then, he goes in, does his deal. And then we, of course, do all of the paperwork and the admin stuff and the ordering of the medications and, like I said, order the MRI and whatnot. So that is when we're in clinic, which is typically half days. And Wednesday we go all day, and then Tuesdays he's in surgery all day.
Got it.
So I would say I'm similar to Sarah. So I see the patient first. So I would evaluate them. So I would take like a pretty thorough history. If they already had like radiographs, I would review those, examine the patient, and then I'd come out and present to the physician. And a lot of times I present in the case of like, is this surgical? Is this not surgical? And what are we going to do? So if it's like, we do upper extremity, so I do mostly hand and wrist. So if it's a wrist fracture, say this is the type of fracture, this is surgical. This is when I think we can do it. Here's what's his insurance. This is where I think we should schedule it. This is where we have time. This would be most appropriate. And if it's non-surgical, I'll say like, okay, I would put this patient in a short arm cast for X amount of weeks, see him back in 2 weeks, radiographic follow-up. Next, rinse, repeat times 55.
Right. Now,
yeah.
And and you work with the same physician mainly
every day.
Time. So, and does he have a PA?
No.
Okay, got it. So obviously, and that's the other thing is physicians are so picky about their preferences, So it sounds like you really have learned your doctor's preferences and they trust you and you guys have a flow going. That was another thing that I found really intimidating, was because the practice I was in, we had multiple physicians that we were working with. Obviously we had our mainstays, but we had about 10 different ones that alternated days. So learning all their preferences about, what films to get, what to order, their injection preferences, all that stuff was a whole other ball game for me. And it made me nervous. I'll be honest, it's a bit intimidating, but I think, again, building those relationships with the physicians and understanding, having those intellectual conversations, because a lot of the times we don't, well, at least ATs and especially high school settings, we don't have anyone there to bounce ideas off of. We don't have anyone to talk about, this person's presenting really weird, what do you think, or what's the best way to go about this? So I think that's just can expand your knowledge base, is getting to know these physicians and understanding, okay, why isn't this surgical this time? Why might you do surgery on this versus this patient? I just had a kid yesterday, tibial plateau fracture. I went in for his appointment with him and I was, discussing options with the doctor about, his spacing displacement was 4 millimeters this way, but 5 this way. And it's just on the cusp. And, it's really interesting and can really just open your mind to, think about injuries, the full picture of this injury. So I think that's really interesting to do. And one thing I particularly enjoy. Now, again, there's a lot of interest in making the switch to this setting. What do you think AT should know prior to, trying to get into the physician practice setting? What is one thing you think everyone should know?
I think organization and administration is huge, because like my job is to keep him on task and to make that clinic run as efficiently as possible. Sound very similar to what Tara was just saying. And I think I wholeheartedly agree with her. If you are looking for more normal hours, that's not the reason. And I think I see that with more new grads. I think because the profession as a whole, we did ourselves a big disservice as far as hours and pay. We all know that. But I think there is a population of newly certifieds that are, looking to kind of circumvent that and look to the physician practice as that out, so to speak. And I agree with her. That's not the reason to get into it.
Yeah, I definitely agree with that. I think one of the other things, and the things that Sarah mentioned are really important, and they're on the job training. So a lot of it is like, you're going to have to get it wrong. Just like you were talking about, Sarah, with like the coding. If you don't know, you don't know. But some of this is going to be on the job training. Like, no one showed up the first day and was like, I know exactly how to code a new office visit. No, you have to be taught. So there are some things that you're going to have to learn. But I think when I first made the switch, a lot of athletic trainers kind of looked at me like I was selling out. And I was like, I do the same job you guys do. I just do it in a different building. Like, right. So like, I was examining an ankle the same way I would on a sideline on a 17-year-old, just that my patient's 70. Like, I'm doing the same test. I'm doing the exact same thing. So I think sometimes people forget that like, your skills are the same, no matter if you're outside or inside. Like, if you know how to examine an ankle, then you know how to do it anywhere. Like, that part is not different. The other thing I would think is kind of like you mentioned, Hope, like, doctors are kind of particular, especially surgeons. If you're not doing a good job, they're definitely going to let you know. And it's going to be more than once, and it's probably not going to be nice. So I think you have to be able to take some criticism and some feedback, and know the things that you don't know. I think that's just part of the job.
Yeah. I think it took me, I want to say it was like a 4-month, the person that I was replacing, she told me it was probably about a 6-month learning curve for her. And I honestly, when I first made the switch, that first week, I came home and cried and was like, what did I just get myself into? And it was literally like 4 months into it, I came home one day and was like, this is okay. I can do this. And honestly, and now I love it. So
I'm never going to cover another soccer game. That's for sure.
Oh, I know. I think there's so much pride in like being down in the trenches, being there. There's a lot of, I think a lot of ATs get a little bit defensive of that, especially there's always the, high school versus college debate always going on, but like you said, you're still doing the same job. It's just a different setting and maybe slightly different patient population, but it shouldn't really matter for anything.
And I never understood the defensiveness. Like, I don't know. If we're going to play Misery Olympics, like, I don't want to play. Like, if you've been on a field for 14 hours and can't go to the bathroom without someone knocking on the door, I don't want to play this game. Like, let me find you a job, because that sounds terrible.
Yeah. Again, it's like a badge of honor.
And that's a problem with our profession. In general, male and female. Like, sorry, being tired and broke, I don't want to play that. I'm serious. That's a big problem. Like you said, Sarah, we've done ourselves a huge disservice with hours and pay. So like, making it a joke isn't like helping the problem. Like, if people want to say like, oh, I'm underpaid and overworked. Okay, well then do something about it in whatever setting you're working in. Like, show your value, figure out how to do that.
And I will say, when I was in the collegiate setting, working 75 hours a week and getting paid a pittance of a salary, every once in a while, I would just get so upset. And my husband would be like, do you love what you do? I'm like, yes, I do. He's like, then shut up. And I'm like, fair enough.
Do it or don't.
Yeah. No, I agree. I definitely agree. And I think it's all, you have different phases in your life, new grad versus 20-year grad who might have a couple kids, that's different phases in your life. And you have to take a step back and say, do I dread going to work every day? Am I miserable when I get home? Am I not feeling fulfilled in my practice? And that's really what we should be looking at, not the label on Division I physician practice, all that stuff. Are you fulfilled? Are you doing what you wanted to do? Are you stable mentally, emotionally, financially? It's a full circle approach here. So I don't really get the misery index type stuff either, but what can you do? It's going to be a long process to kind of change that mindset. And I'm hoping with, going to entry-level masters, I'm hoping that mindset kind of starts to change a little bit. but we'll see. I guess we'll see how it goes. But I also think that being in the physician practice setting kind of gives us an opportunity, or I saw it as an opportunity to educate some of these physicians who might not have worked with athletic trainers in the past. Yeah, I had quite a few of those physicians who didn't realize my knowledge until I, was standing beside, oh my God, I can't talk, beside them looking at an x-ray saying, oh, that has a lot of displacement. Are you going to put and they didn't realize that I had this knowledge base, and it's a door opening to, educate physicians about what athletic trainers can do and have them advocate for us as well.
And I think, or the question that I often hear is, well, how do you get into this setting? And honestly, I don't have really any nugget of advice or wisdom for that, because like I said, it was one of those things. I mean, my whole career, every position has fallen in my lap.
Sorry, I got blacked out.
I'm like, where'd she go? The people that I used to work with knew that I was looking to get back into it. And the person that was leaving his office came from the program where I used to work. And so it
worked out.
We all connected. Yeah. So
yeah, but I think Sarah, you bring up a good point. Like it was networking, right? Like people who knew you, right? Yeah. But like that's not new. Like that's how you.
Right.
It didn't land in your lap. People knew you were, competent and like a hard worker, and like put those two connections together.
Right.
So you did the work somewhere.
Yeah, and that is the question. How do I get into this setting? How do I get my foot in the door? And it's, again, so variable state to state. Obviously, with licensure, California, we have a little bit more leeway, but networking, we all stand on the sidelines of football games, and there's bound to be a team doc on one of those sidelines. Go up, strike up a conversation with them. Have you ever thought about incorporating ATs into your practice? There are no limits. I don't think. I think there is an opportunity for us to get into these practices more and show what we can do, because we can be very beneficial to the flow of clinic.
I think too, like social media groups, just like this one, you ask a question, does anyone know who hires athletic trainers in this area? When I moved and was looking for jobs, I just Googled like orthopedic practices. I would look through their contact staff and see if they hired athletic trainers. And if they did, I knew that was like a good place to look for a job opening. Yeah. And some of it was just applying for jobs that actually weren't great. Like some of the interview processes I went on, found out actually, they're not looking for an athletic trainer. And some of them will list athletic trainer. So you have to get a little creative. I mean, LinkedIn and any other career type of websites can be helpful, but don't discount just some creative thinking.
Yeah, I think there's a lot of gray area in the physician practice setting that, like you said, a job might not necessarily start out as an AT posting, but hey, you meet the qualifications, apply for it and advocate for yourself. Educate the people who are interviewing for that job about why you can still perform these duties versus, an MA that they might have been wanting to hire.
Right.
Yes, we run into a little bit of an issue where they can't bill for our services, but, I feel like there's enough that we can make up for on the other end where that doesn't really matter as much anymore, especially if you can cast and splint and all that stuff. So yeah, I think the door is wide open if you want to walk through it. You just have to get a little creative for sure. Right. And like you said, build those relationships, which I'm so glad that WAT is doing that for people, because I think a lot of people come to this as a safe space, as I show off my little thing.
Yeah, they're cute.
To ask for. It's honestly the most comfortable fleece. Yeah. Like I'm not marketing right now. It's so comfortable and warm. Anyway, yeah, it's a great place to network and to bounce ideas off of other women who have been in similar positions. And like you two are very obviously you've been in your practice for quite some time now, so you have a lot of knowledge about kind of how it works and how how best to kind of to get into that. But what are, I guess, some maybe pros and cons that you have found in this setting? Things maybe you even might want to change in the future.
Cons. I think some of it is Sometimes educating people. One of the things that just comes to mind all the time is like about their insurance and coverage. And it's like an endless battle with insurance companies, with patients. It's like not something you're prepared for as an athletic trainer. I don't know who really is prepared for that. But sometimes like having these really difficult conversations with patients of like, this is what you have. This is how much surgery is going to cost.
Yeah.
You know, or whatnot, or trying to explain that they don't have great coverage and we can't do their surgery, or it has to be at this location. No, you do not have a choice. Yes, you will have a copay. Yes, this is expensive. Having those conversations, especially when it comes to money and healthcare, can be uncomfortable. That for me, I think, is a con. Some of the stuff that, you know, with maybe like interpersonal office type of staff can be challenging. Again, like not traditionally athletic training. We're kind of like in this, we're brought up in this like sports mentality type of like maybe more casual. So a lot of like office politics, I think, in any type of office setting is sometimes a con, sometimes is a pro. If you, like Sarah said, if you really like your staff, which I do, the people I work directly with are great. But sometimes when you work for a big company, big policy just doesn't take everyone into account.
Definitely. I know my first time learning what a peer-to-peer was
yeah, bless. Just give up now.
No, thank you.
Yeah. Once that happens, you're like, it's getting denied. Sorry.
Yeah. Just send me the letter.
Yeah, exactly.
It's a waste of my time.
Well, and it's crazy. It's just, they just want you to jump through the hoop, because I'll call. And then, you know, once you get past like the first 3 people that are just marking off the boxes of what they need to ask, and you actually get to the physician or the nurse or whomever is doing the peer-to-peer, and then they're like, oh yeah, okay, it's authorized. I'm like, wait, what? Like, that was so like they really just want you to jump through the hoop, and it's so frustrating. Like Tara said, I have patients that pay $800 a month for insurance, and then they get frustrated with us when something's not covered. And I'm like, I feel you. I hear you. Because we only take Medicare and PPO, and I say, you know what? I kind of like my HMO. I mean, granted, I got to stay within my system, but
that, and then you're having this like discussion with the patient at like a time that is just not conducive to learning. Where you're like, well, you're not covered. That's
they're
like,
hurting.
yes, I understand. Right. Like I understand that you have medical coverage. Okay, but it doesn't cover this, and I can't tell you why. You have to call your insurance.
And then, yes, we say, oh, you can call your insurance and ask them why it was denied. And then the insurance will tell them something ridiculous like, oh, they just need to do blah, 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 and it'll be authorized. And
right.
Like,
it wasn't documented appropriately.
Right. And I'm like, no, they're wrong. But okay, I'll jump through that hoop too. And then I do, and then it still gets denied. And then the patient's upset with me. And I'm like,
So I don't know if you're ever prepared for that.
Yeah, that is definitely the not fun part of the job. You know, the pro for me is I learn every day. I learn every day. He's great about teaching, and you see stuff that you wouldn't necessarily see on the field, I think, because we see everything.
Right.
And I've come to realize, like I said earlier, there's a lot of crazy out there. So that's been a big kind of eye-opening for me, and just having to figure out how to tactfully deal with that.
Yeah, a lot of customer service.
Yeah, it's a whole other side of the coin of dealing with difficult patients. You know, a lot of us have stories about a crazy parent that we have to deal with, but here it's you know, the patient themselves. And like you said, no one's going to be fully prepared for the insurance headache that comes with physician practice settings. I didn't realize how much I was going to be involved in getting approval for things, sitting on hold with insurance for an hour, trying to get the right codes, trying to do a stat. You know, it's again, like you said, same thing, just kind of flip-flop. So yes, in high school, we're on the phones with physician offices trying to get them in for an appointment. Here, we're already in the office, we're trying to get them approved for these procedures that we need done. And it's a whole other ballgame. And like you said, not really a conducive time to be, you know, dropping knowledge about their insurance plan and why this isn't covered and why this needs a copay. And they don't realize that we don't have control over that in our office. It's a whole separate entity. And I feel like sometimes people get confused about the difference between a medical office and your health insurance. They're two completely different things.
Two totally different. Yeah.
But sorry, go ahead.
I was just going to say, I do have my office manager who, like I said, she wears 4 or 5 different hats. So she's got her plate full, but she is the one that is the insurance person. She doesn't really have a medical background. So when it comes time to answering the clinical questions and whatnot. And so we actually, we work very well together, which is nice. Because then I have to go through the claims that are not getting paid. And some of them are easy fixes, but then I'll look at one and be like, Kara, I have no idea what to do with this. And then she'll help me with that. So it would be really tough. Like we work in an office that there's 2 other physicians on our same floor that we kind of share spaces with. And they're, at least one of them I know, their staff butts heads. And I'm like, there's no way I could work in this close proximity if we didn't get along as well as we do.
Sure.
Yeah, that's definitely, again, coming from a more solo setting to being with, and, it sounds like your guys' practices are a bit smaller than the ones that I've worked in. But like I had, like I said, multiple physicians, we had receptionists, we had back office staff, we had upwards of 5 to 6 MAs, we had ortho techs, we had x-ray techs, we had everyone. And, it's different because I think also it's ingrained in us as ATs to just get shit done, just get it done yourself. Don't necessarily ask for help or bring other people in, just get it done. But that doesn't always work in this kind of setting. You have to bring other people in on what's happening. And that was definitely a learning curve for me too. I'm a very strong personality. I'm an Enneagram 8, if anyone knows.
Me too. I'm an 8.
Love 8s, but it rubs people the wrong way sometimes.
It does. I'm not well liked.
No, yeah, I get that I'm a bitch when people first
all
meet,
the time.
all the time. But yeah, so that was, I got some negative reviews from my supervisors because I was coming off this way, and I said, well, it's just because I know my stuff, like I'm not trying to belittle anyone, but when I see something that can be done more efficiently, I'm not going to ask that person to do it. I'm just going to do it. And, you got to kind of play the game a little bit in the physician office setting, which I came to learn, which is fine. I think that's a good growing experience for me, something that I can take and grow with throughout my career. So,
and that's something that my doc tells me and my office manager often. He's like, you guys have to delegate. I'm like,
delegating is hard.
It is, because I would rather just do it and know that it's going to get done correctly. Because I don't know when your guys' birthday is, but as a Virgo, it's hard to give up that control. I'm very type A, and so yeah, that's been a learning. And my interns have been great. My office manager has actually been out the last 3 weeks due to a COVID exposure in her family. And my interns have just all said, they're like, what do you need, boss? What do you need? What can I do to help you? And so, we get it done. Like you said, athletic trainers just get it done.
Now, are those medical interns, or are they?
They're students that typically we take students that have just graduated college or taken a gap year while they apply to med school. But we have actually, because he works with one of the local colleges, we were taking some of their athletic training people. But now with the master certification, you come out as a certified athletic trainer. You don't want to take an internship for a stipend that's not going to pay your rent. So it's just, it's nice because you already know how to do the eval. Like, I don't need to teach you any of that. So
yeah, definitely. Well, that's good. I feel like the 3 of us are just on the same page. I love this flow that we have going here. I love it. Now, any advice that you would give an athletic trainer who is looking to make the switch for the right reasons, or that maybe, about to graduate and this kind of setting interests them, what advice would you give them? What do you think that they should know before they, go after this kind of setting for their career?
I think definitely knowing the job description and the requirements, like we've talked about the whole insurance piece of it. But I've also seen, on the Facebook page where people will say, I'm trying to get my doc to understand what I can do, and I don't want to function just as an MA. Well, you should know that going into it. And then you can decide whether or not you want to take that position. So I think just knowing what the requirements are, what's expected of you, and I would say, go in and observe, go in and chat. And that's how I interview because I have new interns every year. That's how I interview them. We have them come in and shadow and observe a clinic so that they can see what it is and see if it's something that they're truly interested in. I can get a fit for their personality and whether or not I think they're going to work, with our small team. And, then they know, eyes wide open, what it is that's expected of them.
Yeah, I think that's a great point, Sarah. One, definitely know the job description, know what type of patients you're going to see, what type of medicine this person practices, what type of team they operate, who you're going to be working with on the day-to-day. We also will bring people in during clinic to interview them. And a lot of it is, hey, you can follow me and see what this is like. We've had people flat out walk out within like a couple of minutes and been like, this is not for me. There've been people that we've asked to leave. We're like, no, this is not cut out for you. And then we've had people who hang around the entire day and like, we'll actually let them take like, brief history. So you should observe for sure. Make sure this is what you want to do. I would say, it's okay to maybe not be that comfortable at first. Like this is something new. This is a change. Like Sarah, you mentioned like the first couple of weeks, the first couple of months might be hard. That's okay. That doesn't mean you're doing it wrong.
Yeah.
I would also say like, if you feel like you're not being used as an athletic trainer and you're being used as a medical assistant, give it time, start small, start with small changes. Don't walk in and be like, well, here's all the things that I can do. And this is how I should change your practice. Because at the end of the day, you're not the provider. Like that's the one thing that I think athletic trainers sometimes have to put in check. You work for a physician, you are not the boss. I have to remind myself that all the time. So at the end of the day, like this, it has to be his preference and not mine. So, start small, start with small changes. Don't walk in on day one and be like, this is my territory.
At least make him think it's his preference.
Correct. That's mind game, like level 5.
But yeah, and I would say, Tara brought up a good point about like even research the physician, like, and that's why I think my doc and I get along so well because, one of the reasons he has an athletic training background and he's a DO. So his philosophy is a little different than, somebody else's might be. What kind of patients do you see? Is it mostly Medicare? And if you're wanting younger athletic population, well, then that's not going to be the place for you.
Yeah.
And he sees everything. I know there are some physicians that just do knee and shoulder. There are some that just do, hand or foot.
We only see upper extremity.
So that would definitely, you would want to know that going in.
Do not let me eval a knee. I don't know what I'm doing. I don't.
So true. I know. And when it's also interesting when you do have those specialized physicians who do, hand and wrist or lower extremity, their exams, like I said, they've been doing this for so long. They have the flow of this special test into this special test into this special test into this. And it's interesting to learn from. And I think, Tara, you brought up a good point, realizing that you have to relinquish that control. You don't make the plan of treatment, as much as obvious the physician might come out and say the same plan that you were about to say, but it's still their call.
Right.
And
it's like 9 times out of 10, we probably get it right. But there is the one time that I'm not right.
Right. Yeah.
It's great humbling when you get it right and he's wrong. That's the best.
Yeah.
I love that.
And it's like, it's okay if that we disagree. It's like, well, I don't think this is the pain generator, but we're going to order an advanced, CT or whatever. And we'll find out like, hey, I disagree with you, but we're going to get to the same place maybe, or like, we're going to find out basically. But yeah, and like, it's okay to be wrong. It's okay to like get it wrong or feel uncomfortable when you first start. You're not going to know it all. It's impossible.
Yeah, I think that's the main takeaway. Be okay with being uncomfortable and be okay with knowing that it's going to be a learning curve and you might not be 100%, this girl's amazing. She knows everything right from the start. And that's fine. Right. It's a learning curve. Okay. You're building relationships with your physician, with your staff. You'll learn what they like. You'll learn how they do things, and you'll grow together, and they will grow to trust you to take on more responsibility and trust your judgment on what you think this injury is. Just the other day, and this wasn't even in the physician practice, I was sideline of a football game and one of my kids posteriorly dislocated his hip, and I knew from the minute that he went down that it was a hip dislocation. But my physician, because she has not been on the sideline much, that wasn't even a thought in her mind. So that was kind of the flip-flop there. But now we have that relationship. That was our first game working together, and now she knows that I know my stuff, and she has also gained knowledge from me. So I think it can be a very symbiotic relationship with these physicians, and advocating for our role and all that fun stuff, which is great. So as we are, wrapping up here, is there anything else you guys want to share? Anything you guys think would be helpful for our members to know about physician practice? Anything we didn't touch on?
I think just reach out if there are other questions. We could certainly answer them like in the group. Don't be afraid to network. I would say like ask people what it's like. They'll tell you the truth. I don't think it's like a big secret. We're not like doing anything crazy. We're like doing the same things and dressed in different clothes. There are skills that I have, but that I think athletic trainers maybe foundationally don't have, but it's because I learned them on the job. It's not because I knew them before I got here.
Yeah. We forgot another pro of physician practice is wearing scrubs and not caps.
I don't wear scrubs.
I only since COVID are we in scrubs.
Really?
Because we have to like just disinfect everything all the time. Yeah, but usually I'm in dress clothes.
Yeah, me too. And it's funny because everyone else in our building, all the other physicians, their staffs are always in scrubs. And I'm always like, I'm so jealous. But my doc is very about appearance. Like we used to on Fridays, we got to wear our Valletta Orthopedic t-shirts instead of and we got to casual. So we don't get to do that anymore.
Oh, yeah.
Okay. Well, this is a COVID change. This is a positive COVID change in my opinion.
Yeah, nice.
Keep it.
Yeah, because when we were like full PPE, it was just easier to wash we had to wash everything all the time, every day. So
yeah, the one thing I was gonna say that I forgot and I just remembered, just kind of about like the schedule. You're not gonna have summers off. You're not gonna have spring break.
No Christmas.
Yeah.
We're working. Thanksgiving, working.
Yeah, I mean, we get, I think it's 8 days. There are 8 holidays.
Yes.
So
the big 8,
we get, so we get those. But on the flip side, there is flexibility in that when we're not seeing patients, if I need to make an appointment for myself or my kids, as long as we have coverage, phone coverage in the office, then I can do what I need to do. And he's very family oriented. If it's anything ever family related, it's, you go do what you need to do and we'll figure it out. But I think that's just something else that if you're looking into going into this setting,
that's a great
you need
point.
to know you're not really, I mean, you get holidays, but it's a day.
You get Christmas
It's a day. Right.
Yeah.
And a half day Christmas Eve if you're
lucky. Yeah. I would agree with that. I kind of forgot about that because now we just work all the time. But I mean, it's up to your boss whether you're seeing patients or not. And sometimes it doesn't matter because I have to be here anyway.
Right. Yeah, because the phone is still ringing.
Yeah.
Exactly.
And when you're the clinical person, you have to answer the clinical questions.
Yep.
I know it was definitely a change to when I had to be up at 4:30 to be in surgery by 6 a.m., and then I was, splitting time. So then I still had to go to the high school and be there until however long and work games, but still I'm not a morning person. So I do kind of enjoy being able to get to work at 12, and I don't mind the late nights as much because I find that I better that way.
Yeah, and that's better for you, and that's okay.
Yeah, everyone's different and how they think. And I think it's also important to know or to, don't put physician practice up on a pedestal. I feel like a lot of ATs do that as like the ultimate goal for work-life balance. And if I get here, everything will be amazing and I will not have no problems. And that's not necessarily the case. You might get there and hate it. You might get there and find that you're, too exhausted when you get home at 5, that, you don't want to do anything that you thought you were going to want to do. So I think it's okay to have, ideas and it not necessarily work out for you. Again, we're all different. We all practice differently. We all have different settings that we kind of fall into that work for us at that stage in our life. And I think it's important to keep that in mind and not necessarily idealize, one setting.
And only the person can create the balance. It's not the job that creates the balance. So it's like, you're going to have to set boundaries no matter where you are working in any profession, in any setting. The setting or like the job is not the solution. It has to be the person.
Exactly. And I think that is some knowledge that you just dropped on us. And I think that's a great place to wrap this up because I could not agree more.
That was perfect.
Thank you both so much for taking time out of your busy days to join us. If anyone has any questions about physician practice, are you guys open to, being contacted?
Absolutely.
Questions? Okay, perfect.
Sure.
Well, we appreciate you. Thank you for being amazing members of WAT, and have a great rest of your day, guys.
Thank you.
Thanks, you
Thank you,
too.
ladies.
Bye, everyone.
Have a good day.